Physio comes down to 3 diagnostic categories and 3 treatment categories. The 3 diagnoses are overuse, traumatic, and systemic. The 3 treatments are for pain, for motion, and for strength. And by strength, I mean balance and mobility as well. Some physios tell me I'm crazy, and this can't be true. Some physios tell me, of course, this is obvious. Why am I saying this? The reason I'm saying this is that physio is all about decision making. We see patients with problems and we need to come up with solutions. I'm telling you this because these 3 diagnostic categories and these 3 treatment categories will simplify your decision making. Any patient you see, you put them in one of these diagnostic categories, you put them in one of these treatment categories, and your life will become so much easier. Let me explain. Physio decision making can be overwhelming and complicated. There's always another special test to try. There's always some different exercise to consider. There's always some whiz-bang manual therapy to do. And there's always some new disease or surgery that you've never heard of, like how do you rehab a patient with long COVID? You can still use all of your physio tissue or impairment diagnoses. My goal is to give you an overview while you still retain your traditional diagnoses, like supraspinatus tendinitis or lumbar segmental instability or patellofemoral syndrome. Those still work. Throughout my years of experience, I've developed this approach that prioritizes simplicity, adaptability, and practicality. It's an overview for a complex situation. The 3 diagnostic categories are overuse, traumatic, and systemic. Your approach to overuse injuries will focus on education to reduce irritation. This is activity modification and self-applied pain-relieving modalities. Pain management. This is inflammation control and passive modalities with gentle, pain-free exercise use. And gradually reintroduce recovery of motion and progress to strength and balance as symptoms abate. Expect a slow recovery. This can take months. This is a frustrating yo-yo between periods of improvement and flare-ups. Emphasize pain-free activity and be responsible for their own self-care. For example, this is tennis elbow, plantar fasciitis, shin splints. This also includes most neck and back pain and deconditioning and overtraining. Your physio approach to the traumatic injuries will focus on education to reintroduce pain-free activity and restore function. Progress patients through the 3 phases of treatment as symptoms allow. Initial pain control, then recovery of motion, then progress to strength and balance and mobility. This emphasizes pain-free activity use. Expect objective improvement every reeval. This can take weeks and months. Emphasize pain-free return to function. This is, for example, post-shoulder surgery, ankle fractures after immobilization. This includes also motor vehicle accidents, falls, shootings, stabbings, assaults. Don't judge me, I worked in Detroit for 20 years. Your physio approach to systemic injuries will focus on education to reduce irritation and safety, including fall prevention. This is activity modification and self-applied pain-relieving modalities. Pain management. This is inflammation control with passive modalities and gentle pain-free exercises. Consider supportive devices, brace, cane, walker. Progress through pain control and recovery of functional motion, and then emphasize strength and balance and mobility as symptoms allow. Expect limited recovery with these patients. Manage their decline. This can take years. Emphasize pain-free activity, safety, fall prevention, and being responsible for their own self-care. For example, this is osteoarthritis, this is rheumatoid arthritis, these are vestibular patients. This also includes patients with obesity, fibromyalgia, and patients who fall repeatedly. The 3 treatment categories are for pain, for recovery of motion, and for strength, balance, and mobility. I go into more details about these treatment categories in my exercise book. Patients progress through these stages to recover function, or they may have a flare-up and go back to being a pain patient for a while. Your approach to the pain patient will focus on education to reduce irritation and inflammation. Relative rest and moderation of activity are key. This is activity modification and self-applied pain-relieving modalities. McGill advocates avoiding aggravating motions and allowing a natural healing during acute back pain episodes, rather than performing specific pain-relieving exercises. Pain management is inflammation control with passive modalities and gentle pain-free exercises. This is the McKenzie approach to exercise. Progress to recovery of motion as symptoms allow. Give this phase 4 to 6 weeks before moving on. Emphasize pain-free activity. This is any acute patient that walks in your door or anyone with a flare-up. This includes vestibular patients. Your physio approach to the recovery of motion patient will focus on education on pain-free exercises to recover that motion. Physio assistance to recover motion may be appropriate. Some use of heat, some manual therapy techniques, but this should not be painful. I would put most of the Mulligan manual therapy techniques in this category. Encourage pain-free activity as tolerated. Progress to strength and balance as motion is restored. Expect objective improvement every reeval, about 10 degrees every month. Remain in this stage until functional range of motion is restored. This should not be painful. Your physio approach to strength and balance and mobility patients will focus on education for pain-free activity as tolerated. Restore functional loss. Pain-free exercise progressions, weaning from assistive devices like going from crutches to one crutch to no crutch, going from an immobilizing boot to an ankle boot to rigid shoes to normal shoes to slippers to barefoot. Discharge the patient to a home program when function is restored or if they've plateaued for 4 to 6 weeks. This is where you use McGill's Big 3 exercises. I prefer closed kinetic chain stability exercises like single leg balancing and planks. Let me give you 3 examples. Each injury area should be considered on its own. Example 1 is a self-employed hairdresser with plantar fasciitis. This is an overuse type injury. For treatment, we must always start with pain control, so look at shoes. Short-term use of a rigid shoe can help. Try standing on a soft anti-fatigue mat or full-length shoe inserts that provide soft cushioning. These are attempts at pain relief while the patient keeps working. Add pain control exercises like pain-free range of motion, gentle stretching of tight areas. This is where your passive modalities are useful. As symptoms abate, you can progress to stretching and balancing. Be sure you're out of the woods before going too crazy with these exercises. Example 2 is a patient with a partial rotator cuff tear doing a fitness exercise class. This would be a traumatic type patient, so expect good recovery unless it's a full tear. Again, start with pain relief. Mostly relative rest for the shoulder. This might include just walking on the treadmill and doing some body weight squats. Then as the shoulder pain goes down, you can recover shoulder range of motion and eventually add strength and balance, like wall planks. Remember to keep it pain-free. My book has loads of these exercise progressions. Example 3 is a patient who fell, a patient with a history of falling. This is a systemic diagnosis. They're going to have this forever. So you have to do some pain relief as needed. You have to recover functional range of motion as appropriate. The emphasis here is on strength and balance and fall prevention. Again, my book has standing exercises and walking balance type exercise progressions. A gait device and home safety need to be addressed, preferably with family involvement. Sometimes physios try to snooker me with some weird diagnosis or a wacky patient that doesn't fit into my scheme. There's always outliers, but not everyone really needs physio. Physio is for functional loss, and that's what we're trying to address here. So keep it simple. Have the big picture perspective as you see your patients. Too often I see physios focus on the tiniest little details. Your patient doesn't need to know the difference between a tendinitis and tendinosis and a tenosynovitis. They need to know what they should be doing to stop the pain and which exercises are most important for them to recover function. These simplified diagnostic and treatment categories make it easier for you to educate your patients on what they need to be doing. What are your thoughts on the importance of a simplified approach to physio practice? And how will it impact your own clinical decision making? My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Let's have fun watching this neat video together. And by subscribing, you'll be among the first to know when new exciting content arrives. Thank you.